So I'm going to start kind of giving an overview as far as generalized anxiety disorders in children and adolescents, highlighting some medications, and then she's going to focus on more psychosocial interventions. If anybody has any trouble hearing me, please let me know. So again, going over the objectives, I'll review the prevalence of generalized anxiety disorder in the pediatric setting. I'm going to highlight a couple of the screening tools that can be utilized to help evaluate for anxiety disorders and help evaluate treatment response. Then I'm going to go over some of the evidence-based medicine practices regarding the treatment of anxiety disorders. And today's topic is specifically focusing on generalized anxiety disorder. And then next week, the topic is going to be more on social anxiety and school phobia or school avoidance. So the first question, so what's the prevalence of anxiety disorders in the pediatric population? So this is from the NIMH website. The lifetime prevalence is about 25%. I've seen more recent reports that even say like 30%. When they look at the severe cases, it's about 6%, 13 to 18-year-olds. There does seem to be a gender difference once you reach puberty. Prior to that, it seems to be about equivalent in males and females, and after that, it's more common in females. So a couple of the screening tools, one of the ones that's helpful in kind of teasing out, whether it's a generalized anxiety disorder, social anxiety, panic disorder, it's called the SCARE. So the Screen for Child Anxiety-Related Disorders. There are two different versions. There's a child version and there's a parent version. The child version mentions if you're giving it to somebody in like the 8 to 11-year-old age range to make sure that there's a parent who's going over the questions with them or the clinician is going over the questions with them so they're understanding it better. There's 41 questions divided into like 4 domains: panic symptoms, separation anxiety, generalized anxiety, and school phobia. So a total score greater than 25 may indicate an anxiety disorder. Could prompt more further assessment. Scores above 30 are more specific. And then you can see they break up the different categories as far as the cutoff scores. The other thing that can be useful as far as monitoring severity and monitoring treatment response is this assessment tool. And this is actually on the DSM-5 website. It's one of the emerging measure assessments. I actually use the GAD-7 more, but I think this actually could be really useful. I use the DSM-5 or a cost-cutting measure assessment for like my initial evaluation. Like has findings that are really useful. For this one, they rate the symptoms from the past week from a score of 0 to 4, and then the score is totaled and then divided 10, and based on that, so if divided by 10, if the score is 4, then that would be considered in the extreme range. So a score of 0, none, mild, 1 would be mild, 2 moderate, 3 severe, and 4 extreme. Sorry, I was just going back. So the GAD-7 I also use frequently. It has a cutoff score similar to PHQ-9, so I usually follow the score of 10s are usually more clinically significant, and the goal in the treatment based on the impact model is trying to get the scores less than 10 or a reduction in scores by 50% within like a 10 to 12 week time frame. So, so what are the evidence-based practices regarding the treatment of anxiety in children and adolescents? So I was going to highlight some of the medications used, and then April will kind of take over and go over some of the psychosocial interventions. But prior to 2014, everything we were using
for generalized anxiety disorder was all off-label because we did not have anything specifically FDA approved for generalized anxiety disorder. In 2014, duloxetine, also known as Cymbalta, became FDA approved for ages 7 and older. So duloxetine, it's a serotonin norepinephrine reuptake inhibitor. The starting dosage for children, I would start probably about 20 to 30 milligrams. There hasn't been shown to be much more significant efficacy over a 60 milligram dosage. So that tends to be the max dosage that I use. There might be differences if you're using it for like neuropathic pain and things like that. So sometimes if I do have somebody that I'm seeing with anxiety and fibromyalgia, I mean, I feel like this is a pretty good starting point to see if it helps with both symptoms, the muscular pain as well. Also commonly use the SSRIs, the fluoxetine, which is FDA approved for depression as well, is commonly used. Starting dosage kind of depends on how old the kid is. I would start anywhere between probably 5 to 10 milligrams. Anxiety dosages tend to be higher than depression dosages. So with anxiety for fluoxetine, I would try to get a target range between 20 to 60 milligrams. The sertraline as well, sometimes starting off with like a low 12.5 milligrams and with a target dosage usually between like 50 to 200 milligrams, so it has a pretty wide range. But it's all based on response. Sometimes if people have a really great response with even 25 milligrams, sometimes I will just keep it at that instead of increasing it. The other medications are approved. So sertraline, fluoxetine, fluvoxamine, and clomipramine are FDA approved for pediatric OCD. So one thing to be aware of, it seems like children with anxiety seem to be more sensitive to potential side effects. Sometimes you need to be cautious with some of the medications that are activating, like fluoxetine. It sometimes makes them feel more jittery prior to feeling better. So just educating the child and the family about that possible side effect, starting low dosages. And same with the treatment of depression. You want to educate families that if the medications don't work right away, it takes at least 4 to 8 weeks to get the full clinical benefit, and that's once the dosage is maximized as well. So just to highlight one of the landmark studies in pediatric anxiety disorders, one of the ones is called CAMS, so Childhood Anxiety Multimodal Study. It's the largest randomized controlled trial for non-OCD anxiety. It was 3 months long. There was close to 500 children and adolescents enrolled. So it wasn't just specific to generalized anxiety disorder. There was separation anxiety and social phobia included as well. But as you can see, similar to some of the depression studies, the combination arm with both sertraline and cognitive behavior therapy had the best response rate with 81% responding.
It's impressive to get a quarter of them responding to placebo, though.
Yeah. I mean, depression studies actually have a bigger placebo. Yeah.
Interesting.
So I am going to turn it over to April Lee. She's going to highlight some of the psychosocial interventions and home-based and school-based interventions.
Thank you, Dr. Thomas. So as she mentioned, I'm going to talk about some psychosocial interventions and considerations for generalized anxiety disorder. And what this chart is showing, this was pulled from the website of American Academy of Pediatrics. And it's just looking at different levels of support for different interventions for anxiety disorders in children. So it may be a little bit difficult to read, but each column represents a different level. So starting from level 1 on the left, which they've labeled as best support, all the way down to level 5, which they've labeled as no support. So in their level 1 category, what they've said is the best support in terms of psychosocial interventions. They've listed cognitive behavioral therapy, CBT with medication, CBT with parents, education, exposure, and modeling. Going from there in level 2, we have assertiveness training, attention, CBT for child and parent, cultural storytelling, family psychoeducation, hypnosis, relaxation, stress inoculation, and level 3 or moderate support, contingency management, group therapy. Level 4 or minimal support, we have biofeedback, CBT with parents only, play therapy, psychodynamic therapy, rational emotive therapy, and social skills. In the last column, which is quote unquote no support, is assessment monitoring, attachment therapy, client-centered therapy, eye movement desensitization and reprocessing, peer pairing, psychoeducation, relationship counseling, teacher psychoeducation. So it might sound surprising the way that they've labeled some of these interventions, but they're not saying that the methods that are listed in levels 2 through 5 are not helpful or not valuable. The way that they've labeled these categories is based on the amount of evidence that is supporting them. So for example, in level 1, the reason why they've labeled it best support is because the criteria that they've given it are at least 2 randomized trials demonstrating efficacy and being superior to placebo or some other form of treatment or equivalent. The experiments must have been conducted with treatment manuals, and the effects must have been demonstrated by at least 2 different investigator teams. So when you're tailoring a treatment plan for your patients, that's not to say that you can only use the methods in level 1. It's just saying that that has the most evidence supporting it. So certainly you can mix and match depending on the situation, depending on the child and the family. It's probably the best to, approach it in many different ways and tailor something special to each case.
So no support might mean that there just was never a study done.
Right. I think it's a misnomer, really. It makes it sound like it's not helpful, which is not what they're trying to suggest. Right.
It's interesting to see the amount of rigorous evidence behind certain things and where more research could be done.
And I thought it was kind of nice, too, that in level 1 you have CBT listed and CBT with medication. So if, for instance, a family is not willing to try a medication for the anxiety, then even CBT is by itself is considered a best support. So I just wanted to talk about some different interventions in various settings, because obviously this is not an isolated disease or condition. So at home, and I've pulled this off of that website listed at the bottom, some of the suggestions that were suggested that you can do at home include being consistent with how you handle problems and administer discipline, be patient and be prepared to listen, avoid being overly critical, disparaging, impatient, or cynical, maintaining realistic and attainable goals and expectations for your child, and do not communicate that perfection is expected or acceptable. Maintaining consistent but flexible routines for homework, chores, activities, etc. Accept that mistakes are a normal part of growing up. No one's expected to do everything well or perfectly. Praise and reinforce efforts, even if you're not successful for a specific goal. I think reinforcing that effort was given is important. And don't treat feelings, questions, statements about feeling anxious as silly or unimportant. So going off of that for school, there's some similar recommendations that were made. So for the classroom, can establish predictable routines, set clear and reasonable expectations, break tasks into manageable units, have specific evaluation criteria, provide opportunities for practice and rehearsal, pair anxious students with peers who are confident and supportive, give special responsibilities, give time to relax when anxiety becomes high, reduce or avoid unexpected situations, avoid punitive and negative attitudes, reduce time constraints if possible, and move the student to a quiet setting with fewer distractions. So there's some repeating overtones in a lot of these messages, which is to have routine and consistency, being patient with the child and having realistic goals and expectations, and also just encouraging, good behaviors along the way.
So, any
The NASP,
questions?
the National Association of School Psychologists.
Right.
Yeah.
Yeah.
Let's look to see what that meant.